The cardioprotective benefits of SGLT2 inhibitors like empagliflozin and dapagliflozin have fundamentally shifted heart failure management. While initially designed for glycemic control, their profound efficacy in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction operates largely independently of insulin or glucose lowering. Instead, they act through a cascade of pleiotropic mechanisms that fundamentally alter cardiac loading, myocardial metabolism, and intracellular ion handling. SGLT2 inhibitors promote glycosuria and natriuresis at the proximal convoluted tubule, but their diuretic profile is functionally distinct from traditional loop diuretics. They preferentially reduce interstitial fluid volume rather than intravascular plasma volume. This decongests the tissues without causing the severe hemoconcentration or organ hypoperfusion that triggers neurohormonal rebound. Furthermore, by blocking sodium reabsorption early in the nephron, they increase sodium delivery to the macula densa. This restores tubuloglomerular feedback, actively suppressing the renin-angiotensin-aldosterone system rather than stimulating it. Here is a summary of hemodynamics and smart diuresis of SGLT2 inhibitors. Fluid compartment target, SGLT2 inhibitors, interstitial fluid decongestion. Loop diuretics, intravascular plasma. Neurohormonal impact, SGLT2 inhibitors, minimal to no sympathetic nervous system or renin-angiotensin-aldosterone system activation. Loop diuretics, significant reflex activation. Macula densa sodium, increased with SGLT2 inhibitors, inhibits renin. Loop diuretics, it is decreased, stimulates renin. Myocardial energetics, the thrifty substrate hypothesis. The failing heart is notoriously energy starved. It pathologically shifts away from efficient free fatty acid oxidation toward inefficient glycolysis. SGLT2 inhibitors induce a state of mild fasting mimicry, shifting whole body metabolism to produce ketone bodies. The myocardium eagerly takes up beta hydroxybutyrate, a highly efficient superfuel. Oxidizing ketones yields significantly more ATP per molecule of oxygen consumed compared to fatty acids or glucose, directly improving mitochondrial efficiency and cardiac contractility without increasing oxygen demand. Despite low SGLT2 receptor expression in the myocardium, these drugs have direct, profound effects on cardiac tissue by inhibiting the sodium hydrogen exchanger 1 NHE1. In heart failure, NHE1 is markedly overactive, pumping hydrogen ions out and sodium ions into the cardiomyocyte. This intracellular sodium overload drives the reverse mode of the sodium-calcium exchanger, pulling calcium into the cell. The cost of calcium overload: impaired diastolic relaxation, lusitropy, increased arrhythmogenesis, and the triggering of autosis, autophagic cell death. The SGLT2 inhibitor fix: by directly inhibiting NHE1, SGLT2 inhibitors lower intracellular sodium ions, preventing downstream calcium overload. This is a primary driver of their massive benefit in heart failure with preserved ejection fraction, where diastolic stiffness is the core pathology. Kidney heart crosstalk and inflammation. By blocking active transport in the proximal tubule, SGLT2 inhibitors significantly reduce the metabolic workload and oxygen demand of the kidneys. This reduction in tubulointerstitial hypoxia lowers afferent sympathetic nerve signaling from the kidney back to the heart. Additionally, this improved renal microenvironment restores normal erythropoietin production. The resulting mild increase in hematocrit improves oxygen delivery directly to the ischemic or failing myocardium. Finally, they actively suppress the NLRP3 inflammasome, blunting the systemic inflammation and subsequent myocardial fibrosis that drives adverse cardiac remodeling.